some context, in September of 2023, EASL released guidelines for the management of suspected ICP. This was the first time that guidelines were released that attempt to divide suspected ICP into 3 groups based on patients' bile acid levels as well as their liver tests. The focus of our study was to assess the clinical utility of these guidelines in our cohort, which is a racially and ethnically diverse cohort in the United States. We've found that these guidelines are effective in risk stratifying patients. Specifically, we see higher rates of adverse fetal outcomes in Group C, which is a group that has elevated bile acids. Interestingly, we also see some adverse outcomes in Group B, specifically high rates of postpartum hepatobiliary diagnoses in this Group B, where patients don't necessarily have elevated bile acids during the pregnancy, but they do have elevated liver tests. One of the outcomes that we took a look at was the rates of spontaneous preterm birth within these 3 cohorts, and we found that the risk of spontaneous preterm birth in Group C was highest. This is compared to both Groups A and B. Interestingly also, we see different demographic and clinical profiles between these 3 groups. So patients that fall into Group C tend to have a history of pre-existing liver disease. These patients have higher rates of history of Hep C and an immune-mediated liver disease as well. Interestingly as well, Group B was most likely to have a prior history of MASLD.
Yeah, so I think it's very exciting actually that we have these guidance for the first time to help us really think about suspected ICP differently than we did before, where before you even confirm the diagnosis, you can think about the different groups and that can help guide your management. And as we demonstrated that knowing which group someone is in can really help your counseling in the clinical setting to say, well, if you're in Group C, you may be at highest risk for preterm delivery, especially if you have markedly elevated bile acids. Interestingly, also Group B had high association with metabolic risk factors, so I think we need to keep in mind that metabolic risk factors are an important contributor to suspected ICP. So I think it's really beneficial in the field to have these guidelines that can help us really think about suspected ICP in a novel way.
We're really excited about the next phase. We hope to leverage our institution's existing biobank in order to incorporate genetic findings into these clinical phenotypes that we've described, and this would help us to better risk stratify these patients. We'll definitely take a look at the known genetic variants with cholestatic diseases to see if there are specific variants associated with each group.
And I think really it will be very exciting to also do this prospectively, where we can actually now, with this new criteria, look at the different suspected ICP patients and then prospectively do genetic testing and then also follow them postpartum, because I think a big question is how many of these people will not just have ICP but will go on to develop potentially a chronic or genetic liver disease.